Thank you very much for your invitation and for giving me this opportunity to talk about the new concept of meta-networking that we developed about over 1,000 wake surgeries in low-grade glioma. Namely, now we can say that thanks to this connectome-based surgery, we were able to increase the survival over 17 years with quality of life very good in 99% of patients, speaking about more than 1,000 surgery. And we achieved this goal by doing maximal resection and, if possible, sometimes a supratotal resection, and of course, by preserving the connectivity according to a better understanding of the functional anatomy of the brain. I will not insist on the fact that if left untreated, low-grade glioma will become malignant and will finally induce a deficit of cognitive functions, neurological functions, and to kill the patient. But if you are objective, if you do an extensive neuropsychological examination before surgery, which is more or less never done in 99% of department of neurosurgery, you will see that in more than 50% cases, patients already exhibited some degrees of cognitive and behavioral deficit. And this is related to the invasion of the white matter tracts, once again, before any treatment, demonstrating that this is the limitation of neuroplasticity. When I started over 20 years ago, the median survival in low-grade glioma was 6 to 7 years. Then we published over 1,000 cases that by doing earlier and maximum safe resection according to the connectome, then the survival was over 15 years. And very recently, we also confirmed this data by demonstrating that not only the survival continued to increase over 16 years, but also with a very good quality of life, at least for over 12 years. So how we achieve this goal? By doing mapping techniques, because we have all a different brain. And of course, we have definitely to accept, even neurologists, it's almost done, that localisationism does not exist, and that we have to understand not only the networks of the brain, but the interactions between networks, the concept of meta-network. To do it, of course, fMRI and DTI are very good for didactic and research purposes, but at the individual level, definitely into the operating theater, it is not reliable. And this is the reason why we decided over 20 years ago to do a systematic cortical and subcortical mapping in awake patients, at least, of course, when they had no severe deficit before surgery. But once again, the goal is to arrive earlier. And then we did anatomofunctional correlation by incorporating tests according to the definition of the quality of life by the patient himself, namely not, of course, to avoid hemiplegia and aphasia. It did not induce any hemiplegia for more than 15 years, but in order to give them the opportunity to return to normal life. And we have to preserve the projection fibers, the association fibers into the operating theater, because for younger people, you have to understand that if you cut 3 more millimeters in the depth, you will disconnect 2/3 of the hemisphere, and then the patient will not recover. So this is the reason why I do not use any technology into my operating theater, no navigation, DTI, fMRI, intraoperative MRI, and so on, and nonetheless, I have 99% of reliability. Why? Because definitely I understood it's not a scoop that there is no one major and one non-dominant hemisphere, but we need both in order to make brain. And this is the concept of connectivity. Indeed, in the so-called right non-dominant hemisphere, this side is critical for complex movement, like to play music or sport. For driving, for social cognition, in order to continue to be connected to others, for executive function, but also for emotion, personality. So this is far beyond to avoid hemiplegia and aphasia. And this is absolutely critical because my patients are living more or less 1 generation, 2 decades now. So you will tell me, is it possible to monitor this kind of higher cognitive functions into the OR? And definitely my answer will be yes, because the goal for us is to ask the patient to do multitasking, namely to move, but also to speak, but also to self-evaluate, but also and so on and so on. Just in 4 seconds, without any rest, for 1 to 2 hours, so with a sustained attention. And finally, my surgeries, so the duration is very short now because the patient should be really connected to so many functions, including to preserve the bimanual coordination, thanks to intraoperative cortical and white matter mapping. And you can see that when you stimulate the frontostriatal tract and or the fat, then you will induce bilateral arrest of movement, which is critical if the patient is a golf player, for instance. Also, the line bissection task in order to continue to drive. Otherwise, you can have hemi neglect. I mean, sometimes it could happen. No, I do not want to have any problems. I want for my patient to return to normal life in more than 99% cases, including working full time. Broca's era does not exist. And it was maybe my imagination a few years ago, but it has been replicated. Recently, in a paper we published with San Francisco and Shanghai, demonstrating that it's not my imagination. And even now, neurologists this year finished by publish that you can read by yourself, and maybe Broca's era is not the area of speech, especially if there is a preservation of the connectivity in the depth, including after stroke. But neurosurgeons say that for many decades. So we have definitely to have a mind, our mind of neurosurgeons, understanding the principle of connectivity, not just because it's beautiful to publish very high-level article in good journals, but also because this is the truth into the operating theater when you operate patient, to be connected to the connectome, because there is a very high inter-individual anatomofunctional connectivity and variability in this connectivity. Recently, we published paper demonstrating that not only the left, but also the right I4 inferior fronto-occipital fasciculus were constituted by several sublayers involved in mentalizing, namely theory of mind, namely empathy, so critical for social cognition, but also for higher executive functions like multimodal semantics. I mean, of course, you can say my patients are not hemiplegic aphasic, but they will not be able to return to normal life, especially if you did not preserve this capacity of mentalizing mirror neuron, I mean, to communicate with others, but also by understanding their intentions. This is critical for human beings. And recently, we incorporated new tasks regarding the metacognition, I mean, knowing of knowing. You will say just for research. No, it's in order for you as human being to know what you would like to develop for the next 10 to 20 years. And it's possible in my patients because they are living now more or less 20 years to make, to buy a house, to have a baby. This is absolutely beyond just to be able to move or to speak. But fortunately, neuroplasticity exists. So when I come back and I did that more and more and more, then each time the brain changed, because there is not only variability from one patient to another one, but also within the same patient over years. And then you can remove more tumor, and then your patients can live longer. Nonetheless, you can preserve the connectivity, and especially to understand that SMA syndrome is related to decrease of the interhemispheric connectivity. So by applying this concept, if you were not able to remove the inferior frontal gyrus in the so-called left dominant hemisphere during the first surgery, then you can do it 5 to 10 years later, of course, by preserving the connectivity. So my results about the first 870 low-grade glioma I operated on within so-called eloquent areas, Broca's area, Wernicke's area, central area, corpus callosum, blah, blah. Mortality, 0. 0.5% of severe permanent aphasia, there is 0, does not exist. But 99% of patients return to normal life with a 25% of improvement. Remember, 50% of them are not so well before any treatment, if you do an extensive cognitive assessment, plus 80% of positive impact on epilepsy. So we increased their quality of life. And of course, you will tell me, yes, but sometimes you stop a little bit too early. So finally, you will decrease the chance for the patient to live longer. No, I will come back, not only a second time, but also a third time. And we published recently the sole paper in the literature demonstrating that the brain changed not only during the first and second surgery, but also during the second and third surgery. And then you can see median survival now, 18 years with a good quality of life by dealing with mechanisms of neuroplasticity. Median survival over 17 years. 97% of my patients resumed their return to their employment, which is unique in the literature, despite supratotorization. It's not incompatible. Why? Because we started really to understand the limitation of neuroplasticity, and in vast majority of cases, the white matter tract, which could be invaded by the glioma. So we have to be neuroscientists, and I will continue until the end of my career to say that to younger people, we are connected to the connectome of human being. Our responsibility is to better understand how the brain is processing, and then to propose, as neurosurgeons, new models of cognition to neuroscientists. It's exactly what we did. We published the sole atlas in the literature of cortical and white matter tract, critical for the function in 16 functional domains. And of course, in the M&I template, and of course, for neuroscientists also, published in NeuroImaging. But in order to help younger surgeons, we publish a software allowing to implement the MRI of these patients you will apply tomorrow in this atlas. But by taking now into account the relationships between networks involved in language and movement, in connection, in mentalizing, and so on. And of course, taking it into account these relationships between both hemispheres. Definitely, minor hemisphere means nothing. And suddenly we understood that in fact the brain was not rigid, of course, but it's a perpetual succession of equilibrium states. And then you create new, modifying the weight between and across networks according to the environment in order to adapt. This is the principle of neuroplasticity. You will tell me what will be the applications into the OR. Please ask the patient to do a multitasking, to move and to speak simultaneously. And sometimes you will be surprised by stimulating to see that the patient is still able to move, still able to speak, but not to do both simultaneously. And of course, he will not return to normal life, even if he's not hemiplegic aphasia. And this is critical for rehabilitation following surgery, because you can remove Broca's error if you understood that not only you will see a reorganization within the language network, but a modification of the weight with stronger connections between the network involved in language and network involved in executive functions, working memory, mental flexibility, attentional processing. And this is why patients are able to recover, especially if you start to induce by yourself these mechanisms of neuroplasticity, plasticity of plasticity, learning of learning. And this is critical for our patients, because this is the reason why I started to reoperate some patients a fourth time with 20 years of follow-up while they enjoy a perfect normal life, and of course, without cryotherapy. So the message is talk to the brain. And of course, when you are into the operating theater, speaking about diffuse glioma, which in essence are not well delineated, see the brain and do the resection according to the cortical and subcortical mapping and cognitive monitoring. So be careful about technology, because never today DTI into the OR will give you this kind of higher level integrated information. Please ask directly to the human being himself. So my conclusion is very easy. You have now the choice just to remove a tumor mass using your navigation, intraoperative MRI, what you want, and to say, I did my job, versus to understand how the human being brains is processing, and to act accordingly, not only today into the world, but by anticipating what will happen within the next 5, 10, 15 to 20 years. Beyond that, I'm sorry, I don't know. I am not so old. So I will continue. And if I can do it, please do it by yourself. Thank you so much.